With us today, we have Kyle Ganson, who has a MSW, LCSW, LICSW. He's a doctoral candidate and adjunct instructor at Simmons University School of Social Work and a clinical social worker licensed in both Maine and Massachusetts. Kyle has over 7 years of postmaster's clinical experience working with adolescents and adults in a variety of mental health care settings. His clinical experience has largely focused on individuals and families experiencing major mental health concerns with a particular interest and expertise in eating disorders treatment. Kyle's research agenda stems directly from his practice experiences, particularly the exacerbation of mental health and social problems due to lack of resources, policy constraints, and uninformed practitioners. Given these barriers, his research agenda focuses primarily on the etiology, prevention, and intervention of eating disorders and muscle-enhancing behaviors among the underserved and underrepresented and under-researched male populations. Kyle's research has been published in a variety of peer-reviewed journals, including JAMA Pediatrics, The Lancet, Child and Adolescent Health, Eating Disorders, the Journal of Treatment and Prevention, and Substance Use and Misuse. Kyle has also presented at both national and international conferences. In addition to his clinical experience and research, Kyle has been teaching MSW students at Simmons University, both on ground and online, for over 5 years. He has primarily taught clinical practice and research courses. Kyle's teaching philosophy emphasizes experiential learning, and he regularly incorporates information on the assessment and treatment eating disorders in his courses. So please join me in welcoming Kyle to the university.
Thank you. Thank you. I feel like I don't have to do my presentation anymore. So I am Kyle Ganson. I'm a doctoral candidate at Simmons University School of Social Work. And today I'm going to be talking about eating disorders among the college male population. The title of my presentation is Understanding the Relationship Between Eating Disorders, Sexual Assault, Non-Suicidal Self-Injury, and Suicidal Behavior Among a Population of College-Enrolled Males. And I'm going to say those words a lot. We're going to have to listen carefully because there's a lot of non-suicidal self-injury over and over again. So here's a little background of what we're going to talk about today. I will talk a little more specifically about my clinical experience, talk about my overall research agenda, and then I'll kind of go into the sort of known gaps and sort of study rationale for my research area. I'm going to discuss the study aims that I have for the 3 papers that I will discuss, the conceptual framework and methods of how those papers were conducted. And then, of course, I'll present the three studies. Obviously, this is applied research, so we're trying to actually make a clinical impact. So I'll talk about the implications of the research, and then discuss my future research directions and where I'm going from here. As was mentioned, I have over 7 years of direct practice experience working with adolescents and adults experiencing a variety of mental health concerns. And I've worked in a variety of settings as well, residential programs, day treatment centers. I've worked in emergency departments, and I'm currently an outpatient private practitioner. Like was mentioned, I'm independently licensed in the state of Maine and Massachusetts. And overall, my specialty is eating disorders treatment. And this is essentially what drives my research agenda and my research interest. It's through my clinical practice experience, witnessing the negative impacts of lack of resources that clients have, different policy constraints that get in the way, like insurance, et cetera. And then, of course, unfortunately, uninformed practitioners, the lack of knowledge around how to treat eating disorders effectively. So here's just an overview of my research agenda and what I'm particularly interested in. Kind of at the broadest point, I'm particularly interested in boys and men's health. Within that, I'm interested in these sort of 4 major topic areas: eating disorders, muscle-enhancing behaviors, high-risk behaviors, and violence victimization and perpetration. And then, of course, you can sort of go a little bit deeper at the next level and sort of look at more specifics of certain areas within these basic topics that I'm interested in. I've boxed red around 3 of these 4 areas because those are what I'll be talking about today. So my primary area of interest is the eating disorders and muscle-enhancing behaviors among men and boys. But there is a connection between these multiple areas that are important to highlight. So just to give you some background on eating disorders, if you're not familiar, eating disorders are pernicious psychiatric disorders. They impact individuals on many different levels, physiologically, psychologically, and socially. They adversely affect every system of the body. They have some of the highest comorbidity mental health rates and substance use rates. They have the highest mortality rate of any mental illness, including both intentional cause of death like suicide and unintentional like physiological medical complications. And also there's significant social aspects that impact these individuals, like relationship issues, financial issues, etc. Interestingly, eating disorders are one of the most gendered disorders. Overall, they are more common among women and girls. Therefore, socially, we've kind of perceived them as this female disorder or something that only impacts women. And given that, less than 1% of the eating disorders research has actually focused on the male population. So there's a huge gap in knowledge to understand what's going on among men who experience these conditions. And I should say that when I talk about eating disorders, I'm particularly talking about the three sort of major ones, which is anorexia nervosa, bulimia nervosa, and binge eating disorder. There are other disordered eating and eating disorder behaviors, diagnoses, but I'm particularly interested in those three. So eating disorders among men. So compared to women, men often have higher rates of psychiatric comorbidity and substance use comorbidities, which obviously complicates treatment in multiple ways. Men also may actually have higher rates of mortality from the illness compared to women, though there's still sort of debates in sort of how we measure mortality due to eating disorders in general. Importantly, boys and men are often underdiagnosed and undertreated. They're overall less likely to seek treatment themselves. In two studies that I highlight here, in one study that found that 5% of assessments over a 21-year period at an eating disorder program were male. So over 21 years, only 5% of those people who came in for assessments were men. Similarly, only 10% of adolescent boys with eating disorders will seek treatment for care. So there's a huge lack of diagnosis and lack of treatment happening. And part of the reason that there is that case is that there's no clear and concise medical treatment guidelines to actually guide how we treat and engage these people. And I'll come back to talking about the medical treatment guidelines in a little bit. So what we do know about eating disorders among men, what we don't know about eating disorders among men is that we don't really know a lot of the etiological risk factors, what kind of leads to these behaviors, and we don't really know a lot of the associations, aside from some more general sort of psychiatric and substance use comorbidities. We really don't know a lot about the physiological and social outcomes, particularly among this population. And we also don't really understand the psychological mechanisms that underlie the development and maintenance of these issues. Among women, though, we do know there's associations with sexual assault victimization, non-suicidal self-injury, and suicidal behavior. We obviously know a lot more about women and eating disorders. I'm just highlighting these three because that's what I'll be talking about today. So therefore, the three aims of my study, which I'll share with you and go into a little more depth with. The first study was to investigate the association between sexual assault victimization within the last 12 months and screening positive for an eating disorder among college men. The second study was to investigate the association between eating disorders, non-suicidal self-injury, and suicidal behavior among college men. And then the third study was to investigate the direct and indirect effect of emotion regulation on the association between sexual assault victimization and those three outcomes: eating disorders, non-suicidal self-injury, and suicidal behavior. So the overarching sort of conceptual framework of how I tried to understand these three separate but connected studies was using this emotion regulation model. And emotion regulation is essentially the ways that we consciously or unconsciously manage our emotions based on different environmental situations. Most of us fall into this adaptive emotion regulation techniques where we might reappraise the situation, we might do some problem solving, we might actually accept that we can't really change what's going on in the moment. Other times we'll fall into these more maladaptive techniques, which is like emotion and thought suppression, experiential and behavioral avoidance, and rumination. So a lot of those sort of more associated with mental health outcomes. And because of that, if people who engage in more maladaptive emotion regulation often have increased psychopathology, so anxiety, depression, et cetera. And we know that individuals with eating disorders have difficulty not only identifying their emotions, but regulating them as well. Therefore, we can sort of conceptualize eating disorders, and this is how I've conceptualized these behaviors, like restricting, binging, purging, et cetera, as some form of maladaptive emotion regulation technique, and or they're exacerbated because people don't know how to regulate their emotions in an effective way, so they turn towards and have more likelihood of these behaviors. So in order to address these aims of my studies, I used the 2017-2018 Healthy Minds data set. This is an annual cross-sectional study out of the University of Michigan. It's been going on since about 2007. And they survey over 50 colleges and universities across the United States. In this sample year, there was over 68,000 participants, so a very large sample size. I only included men who identified as cisgender, so their sex assigned at birth and their gender identity as male. And that roughly brought the sample to about 21,000. And then the final analytic sample after accounting for missing data was somewhere around 15,000. And so my main outcome variable was eating disorders, not surprisingly. And in order to measure that, I used the SCOFF tool, which is part of this survey. It's a 5-item yes/no responses to each of the items. Traditionally, it's been used that if you say yes to 2 or more of the 5 questions, you screen positive for an eating disorder. It's important to note this is not a diagnostic tool. It's not meant to say you have anorexia or you have bulimia. It's meant to just say there's some red flags here, further screening is needing. So it's a screening tool. And I looked at a variety of independent variables, sexual assault victimization in the past year. This was a dichotomous yes/no. And this was all-encompassing of sexual assault. It included rape, but it also included things like coercive, touching, et cetera. Non-suicidal self-injury in the past year, there was a long list of types of non-suicidal self-injury, like cutting, hair pulling, head banging, et cetera. I sort of dichotomized those into I've done any of these or I've done none of these. Suicidal ideation in the past year, just a dichotomous yes/no. Have you experienced this? Suicide attempt in the past year was dichotomous yes/no. And it was only asked, importantly, it was only asked of people who said yes to the suicidal ideation question, which I'll talk a little bit about as I present the results. So there was some skip logic in the survey that only those who had said yes were asked that question. And then emotion regulation was measured using the acceptance and action questionnaire. This is a 7-item Likert scale responses. And I recoded this variable and aggregated it to be so one variable that's scored from 0 to 42, higher scores indicating greater difficulty with emotion regulation. And not surprisingly, given that there's a lot of comorbidity, I looked at a variety of covariates like anxiety screening, depression screening, alcohol use, illicit drug use. And I also looked at the flourishing scale, which is just a general measure of how well someone is flourishing in their lives. Are they doing well or are they not doing well? And then, of course, I looked at a variety of demographic variables like age, race, ethnicity, sexual orientation, degree program, residence, and relationship status. So here's just the basic descriptive results of the sample. You can see that most of the students were between 18 and 20 years of age. 60% or so were white. 85% or so identified as straight or heterosexual. And 63% or so identified as undergraduate students. So not a super surprising, it's pretty representative of what you would get in a college survey. And just again, remind you, this is only cisgender men. So my first study is titled Sexual Assault Victimization is Associated with Eating Disorders Among College-Enrolled Men. And just to remind you of the aim is to investigate the association between sexual assault victimization and screening positive for an eating disorder among college men. Not surprisingly, my hypothesis was, in fact, that there would be an association between these two variables. And I conceptualized this, again, using that emotion regulation framework. This conceptual framework sort of outlines an activating event. It's kind of weird because it's right in the middle of that cross. You can see an activating event might occur, which is in this case a sexual assault. There's an emotion state change that often occurs with a sexual assault. People have difficulty with regulating their emotions. That can be hyper or hypoarousal, sort of things like anxiety or depression. Then, of course, when someone's in that state, they need to regulate their emotions in some way. They can choose the adaptive way, which is sort of that reappraisal, mindfulness, acceptance, etc. Or they might actually take a maladaptive route, which could be restricting, binging, purging, some of those more eating disorder behaviors. That, of course, temporarily regulates the emotions until some other activating event occurs, which could be just like a trigger or a flashback, or maybe even re-victimization. So that's sort of the conceptual framework that I've used to sort of understand why there might be an association between sexual assault victimization and eating disorders among this population. So the descriptive results of the major variables in this study, eating disorder screens, you can see that roughly 15.5% of the college men in this study did screen positive for an eating disorder. That's actually significantly higher than other studies, so it's a little bit of a surprising finding. Most studies using the Healthy Minds study have found between 3 and 5.5% of men screen positive. So something is happening maybe in this year that has gone up. And sexual assault is a little over 3.5% have experienced a sexual assault within the past 12 months. And that's slightly lower, though not significantly lower than other studies that have investigated sexual assault among college men. And so in order to address the aims of this study, I used logistic regressions in order to adjust for the covariates and the demographic variables. And so you can see at first I just looked at sexual assault and screening positive for an eating disorder. And you can see that if you said yes to experiencing a sexual assault, you did in fact have greater odds, significantly greater odds of screening positive for an eating disorder. And that's again adjusting for the demographics and the control variables. I wanted to actually look a little bit deeper to understand some more of the nuances that's happening in the sample. And what I did was, given that we know that individuals, men in particular, who identify as gay or bisexual or unsure of their sexual identity, they are more likely to not only experience sexual assault, but also to experience an eating disorder. So what I did was I created a combined variable looking at both sexual assault victimization and sexual orientation and how that impacts the relationship between screening positive for an eating disorder. And so you can see that if you did, in fact, identify as having a sexual assault and identified as a sexual minority, so gay or bisexual or unsure, you had significantly, over twofold, the greater odds of screening positive for an eating disorder compared to the men who didn't experience sexual assault and who identified as straight or heterosexual. So just some nuances of understanding of what's leading to those eating disorder behaviors. So the major findings of this study is that the hypothesis is confirmed that eating disorders and sexual assault victimization are associated with each other. And this might be particularly strong among college men who identify as gay or bisexual. So my second study is exploring the association between non-suicidal self-injury and suicidal behavior and eating disorders. So again, to remind you of the aim was to investigate the association between these variables. Not surprisingly, I hypothesized that there would, in fact, be an association between the variables. And I, again, use this emotion regulation framework as a conceptual model. And if you look at the major theories of eating disorders, non-suicidal self-injury, and suicidal behavior, there are constructs within those theories that are directly related to or somewhat inadvertently related to emotion regulation in some capability. So if you look at this, the transdiagnostic theory of eating disorders, which has a construct of mood intolerance, that's directly related to the integrated theoretical model of non-suicidal self-injury and this construct of reducing negative affect. So I tried to create a little bit of a map to sort of explain why these constructs are related or how these constructs are related among multiple theories of these disorders. So again, the descriptive results, the eating disorder screen is going to stay the same because it's the same sample. So you have a little over 15.5% who screened positive. You have about 18% of the male participants who did engage in any form of non-suicidal self-injury. About 10% who endorsed suicidal ideation in the past 12 months. And of the 10% who identified a suicidal ideation, roughly 8.5% had attempted suicide in the past 12 months. So comparing some of these rates, non-suicidal self-injury were higher compared to rates of previous rates of non-suicidal self-injury in the Healthy Minds study. And rates of suicidal ideation and suicide attempts were also a little bit higher than previous studies. Similarly, I used logistic regressions to investigate the aims, to adjust for the demographics and the covariates. And so you can see I kind of looked at just these variables independently. So non-suicidal self-injury and screening positive for an eating disorder, you can see that in fact, if you did endorse in any form of non-suicidal self-injury, you did have greater odds of screening positive for an eating disorder. Suicidal ideation, same thing. If males engage in any sort of suicidal ideation, they were more likely to screen positive for an eating disorder. Interestingly, suicide attempt was not significantly associated with screening positive for an eating disorder. My hypothesis, and I'll talk a little bit about this in the limitations, is that this might actually be more related to the skip logic that's in the survey. So it may be more methodological than anything, but maybe further research is needed to really understand that nuance. And so again, I wanted to look at some of the nuances of this data. Given that we know that non-suicidal self-injury and suicidal behavior are very connected, I again created combined variables where non-suicidal self-injury and suicidal ideation, looking at that together, and then looking at non-suicidal self-injury and suicide attempt and looking at that together and how those are leading to or potentially leading to eating disorder screens. And so you can see that if you had any non-suicidal self-injury and endorsed suicidal ideation, you had significantly greater odds of screening positive for an eating disorder. And similarly, this is what's a little bit interesting with the suicide attempt. If you engage in any form of non-suicidal self-injury and in fact did have a suicide attempt, you had even greater odds of screening positive for an eating disorder. So it may just be that these behaviors are so comorbid, or the eating disorder and the non-suicidal self-injury may be some form of habituation that leads to maybe a more lethal act like suicide attempts. So the major findings is that the hypothesis is partially confirmed. Non-suicidal self-injury and suicidal ideation are independently associated with screening positive for an eating disorder. However, if you engage in both non-suicidal self-injury and either suicidal ideation or suicide attempt, it increases your odds of screening positive for an eating disorder. So the third study is called Adverse Health Outcomes of Sexual Assault Victimization Among College Men, a Path Analysis Approach. So again, to remind you of the aim was to investigate the direct and indirect effect of emotion regulation on the relationship between sexual assault victimization and those three outcome variables: eating disorder screen, non-suicidal self-injury, and suicidal behavior. And not surprisingly, I hypothesized that there would in fact be both direct and indirect relationships between all these variables. And this conceptual framework is similar to the first conceptual framework, looking at that activating event being the sexual assault victimization, which leads to an emotional state change, which is either hypo or hyperarousal. Of course, at that point, you need to regulate your emotions in some way. And so you can go down the adaptive emotion regulation technique, or you could go into one of these more maladaptive techniques, like eating disorder behaviors, non-suicidal self-injury, and suicidal behavior. So this was the result of the PATH model. So you can see that, again, it's very similar to that conceptual framework. Sexual assault leading to emotion regulation, and emotion regulation leading to those outcome variables. And so overall, you can see that there are, in fact, positive and significant direct relationships between all the variables under study. That being said, they're slightly weak according to sort of traditional coefficient standards. And overall, the model fit is not particularly strong. It's more on the acceptable side compared to traditional fit statistics. And some of the preliminary results do show that emotion regulation does have an indirect effect from sexual assault victimization to those three outcome variables, where if you have more difficulty with emotion regulation, it's a stronger relationship to those eating disorder, non-suicidal self-injury, and suicidal ideation. And so the major findings that the hypothesis is confirmed, that there are positive direct and indirect relationships between all the variables. And like I said, emotion regulation has some form of a mediating or indirect effect on the association between sexual assault victimization and those three outcome variables. So the major study conclusions, among college men, there are significant associations between sexual assault victimization and eating disorders, as well as non-suicidal self-injury, suicidal behavior, and eating disorders. That there are, in fact, these direct positive relationships between sexual assault victimization, emotion regulation, and the three outcome variables. And that emotion regulation does, in fact, have an indirect relationship between sexual assault victimization and the three outcomes. And these associations throughout the studies can be somewhat explained by the emotion regulation model and the emotion regulation constructs that are within the major theories that explain these conditions. So what does this all mean? What is the impact of this research? First of all, eating disorders may actually be more prevalent among college men than previously thought. Like I showed you, the eating disorder rate was significantly higher than previous rates. So therefore, prevention and intervention programming on college campuses should be geared, and men should be included in that conversation. A lot of the prevention and intervention programming right now that is evidence-based is a little more focused towards women. Social workers should be screening for eating disorders among college men who have experienced a sexual assault. This is particularly true among college-enrolled men who identify as gay or bisexual. Social workers should be screening for eating disorders among college-enrolled men who endorse suicidal ideation and non-suicidal self-injury. Men actually may be more likely to either be sort of screened by medical professionals or campus medical professionals for things like non-suicidal self-injury and suicidal behavior. So if we take that one step further by actually asking them and engaging them in a conversation around eating disorder behaviors, we might actually catch and diagnose more eating disorders among men. And social workers should be assisting college-enrolled men to develop adaptive emotion regulation techniques, so move away from those adaptive techniques and instead use some adaptive regulation techniques, and hopefully to reduce the use of these maladaptive emotion regulation techniques. So they provide support for techniques like CBT, DBT, ACT, and mindfulness therapeutic modalities. And just a few limitations that should be noted. The SCOFF tool, so a couple measurement issues. One is the SCOFF tool. This is a general screening tool. It's primarily used in primary care settings, and it's not particularly valid among the male population. It doesn't actually ask questions that are really specific and unique to the male eating disorder experience. So it's likely that there is maybe missing some men, or we maybe even be over-screening at times because there's not a lot of nuance to those questions as it relates to the male population. The acceptance and action questionnaire is just a general emotion regulation and experiential avoidance questionnaire. It's not really specific to the experience of sexual assault or trauma related to sexual assault or eating disorders or non-suicidal self-injury, et cetera. So it may actually not be capturing the nuances of the emotional response from a sexual assault. This is cross-sectional data, so I've created a nice, beautiful pathway to assume that this is all happening causally, but it's cross-sectional, so there's no real causality involved here. So it's really just about associations. I think one of the most interesting aspects of the Healthy Mind study is that it doesn't really capture those who have left college, particularly those who have experienced sexual assault, eating disorders, non-suicidal self-injury, or suicidal behavior. As a clinician who sees a lot of young adults and college students, I see a lot of students who have taken a leave of absence from school. Therefore, we're not actually capturing them in this study. So there's something to be said about missing those individuals. And then lastly, the PATH model in study 3 is not a particularly strong fit, and I think this is likely due to the measurement issues that I mentioned. So that's sort of the 3 studies. I'm going to sort of present to you where my research is going to go and where I hope to go in the future. Just to remind you, this is the overview of my research agenda, looking at men's and boys' health, and eating disorders, muscle-enhancing behaviors, different high-risk behaviors, and violence victimization. I'm going to sort of stick specifically to eating disorders and muscle-enhancing behaviors because that is sort of the primary line that I'm following. And what I'm going to do next is just present to you 4 questions that are sort of the aims and the questions that I hope to answer immediately and in the future. So question 1, what racial ethnic disparities exist among boys and men who experience eating disorders? What are the most effective methods of treating these individuals? So there's a lot of lack of research. There's 1% of research has been conducted among men with eating disorders. There's probably 0.5% of that has been done among understanding the racial and ethnic disparities that exist among this population. Given that we don't actually know how to best treat, screen, diagnose, et cetera, this population. So one of my aims that I have is to increase that knowledge base to really understand the nuances between multiple races and ethnicities other than white. And there's multiple ways to do that. The AdHealth data set is out of the University of North Carolina. It's a longitudinal cohort study. It asks about eating disorders, obviously asks about race, ethnicity, and so really understanding the disparities within that large nationally representative survey. Also using the Healthy Mind study to really highlight the differences among college students. And I think we could use some quasi-experimental designs, collaborating with primary care settings, medical doctors, treatment programs, to really understand what works best in helping these individuals. Ultimately, this is going to inform assessment and treatment protocols for social workers, and hopefully address a social narrative that women and white women are the only ones who experience these conditions, that it does in fact impact multiple populations and many underserved populations. Oops. Question 2. What adverse physiological, psychological, and social outcomes are prospectively associated with adolescent use of legal performance-enhancing substances? That is a mouthful. We know a lot about illegal performance-enhancing substances like steroids. We know there's a lot of really adverse outcomes, whether that be social, psychological, or physical. What we don't know is that these legal performance-enhancing substances, things you can buy at GNC or CVS, et cetera, we don't actually know what happens when people use these long term. And they're widely used, particularly among the male population, and they're unregulated by the federal government. So we need to actually understand what happens long term as you use these substances to really inform policy, to inform practice, et cetera. So again, different ways to do that. The Ad Health dataset has great measures to ask about these different, not only health outcomes, but also the use of these legal performance-enhancing substances. Like I mentioned, this would of course inform public policy on oversight and regulation needs for these easily accessible substances that I should say are often used by young adults and adolescents who may not actually have the decision-making processes to be able to say, I should do this and know what might happen long term. Question 3, which interventions are most effective at addressing legal performance-enhancing substance use among boys and men? So we don't know how to really engage people in conversations about using these, not using these substances. They're, like I said, very widely used, but we don't know, do we treat this like a substance use disorder? Do we need to taper people off of some of the use of these substances? So really understanding how do we engage and treat boys and men who use these substances. And again, this could be done through like quasi-experimental designs, collaborating with primary care providers, collaborating with medical doctors in a variety of settings, as well as social workers to understand how are we engaging these people in treatment. Another great way we could do this is through case studies, is actually following the treatment of individual people over time to see what works and what's most effective. This would, of course, identify evidence-informed interventions for social workers. Question 4, what is the most effective method of increasing male eating disorders knowledge among social work and medical professionals? Like I mentioned, there's a lack of knowledge in general from medical professionals and social workers on eating disorders, particularly among men. And so how do we actually increase that knowledge base and increase the skills of social workers and medical professionals to assess, intervene, and treat these individuals? Again, this could be done through primary data collection, collaborating with the Cleveland Clinic, let's say, or social workers here, social work students here, to really understand how do we train social workers to be adept and knowledgeable in this population. This, of course, would increase knowledge and training, which hopefully would increase diagnosis and treatment rates, and then, of course, decrease that undertreated, underdiagnosed number. And so the hope, I've sort of funneled all these questions down, and the hope is to actually develop specific medical treatment guidelines for boys and men who experience eating disorders. There are general treatment guidelines put out by the APA and a bunch of other organizations about how we treat these individuals, or individuals who experience eating disorders, but they're not disaggregated by sex, and because 1% of the research has been conducted among women, has been conducted only on men, we don't actually have a lot of that knowledge that we need in order to know how to best treat these people. So all of this would sort of funnel down into creating those treatment guidelines that will be serving these individuals. Also, it addresses 2 really important policies. One of them is the 21st Century Cures Act, which is a federal policy that was signed into law by President Obama in 2016. And it's the first federal policy that has any provisions around eating disorders, specifically around increasing medical training and treatment, information for medical treatment and training, as well as awareness and prevention efforts to the general public. So this would actually directly infuse and really be supported by that legislation. There's also a really great sort of model legislation right now in the legislature in Massachusetts looking at actually banning the sale of diet pills and muscle enhancing behaviors to young people. It has a few other provisions around like keeping them behind the counter and sort of listing that there's not a lot of knowledge and oversight of these substances. So this could actually be a really nice model for other states to enact and take over. And this is like the 4th year that it's been in the legislature. There's a lot of emphasis in the Massachusetts community to try and get this bill passed. Oops, whoa, it's going fast, sorry. So how am I gonna do this? Funding goals are super important. So I have a variety of sort of mechanisms that I hope to seek, primarily through the National Institutes of Health, through the National Institute of Mental Health, and National Institute of Drug Abuse. I'm also particularly interested in applying for a K award at some point down the road, which would give me time to really immerse myself in research and conduct and answering a lot of these questions. And it would also give me really nice mentorship capabilities with leading scholars in this area. SAMHSA also has a lot of grant funding for substance use and mental health, which, as you probably can see at this point, that there's a lot of connection between substance abuse and mental health in my area. So that would be another area to seek at for funding. And then, of course, there's a variety of philanthropic organizations that provide eating disorders research funding, but also the Harry Frank Guggenheim Foundation does some interpersonal violence grant funding. And like was mentioned in my introduction, just some background information. Some of my previous publications have been in a variety of journals: Eating Disorders, the Journal of Treatment and Prevention, Substance Use and Misuse, Journal of Social Work Education, Lancet Child and Adolescent Health, and JAMA Pediatrics. I have several studies right now under review at the Journal of Adolescence, the International Journal of Medicine and Adolescent Medicine and Health, and then Journal of Interpersonal Violence. I also have 3 book chapters coming out in the next few years looking at medical complications and medical management of eating disorders among men, as well as an encyclopedia chapter on adolescent eating disorders among adolescent boys. And they should be out, I think, in 2022. And so that's my research. And so how does that apply to teaching? And just to give you a little background on my teaching and my teaching philosophy. I have over 5 years of teaching, primarily MSW students at Simmons University. Given my clinical background, I've taught primarily clinical practice courses, though I have taught some research and statistics courses for social workers. And my way of teaching, my philosophy, is the CER model. It's the content experience reflection model. And so essentially, it's providing some level of content to student, engaging students in an experiential activity in some form or fashion to engage them with the content, and then some sort of reflection activity that helps metacognitively integrate that whole process so students feel prepared to really know what they learned, how they learned it, and then apply that to their outside work. And I underlined and bolded the experience part because I really believe strongly that we're a practice-based profession, so we need to be educating practitioners how to practice out in the field. And so my emphasis is on how can we create as many experiential activities to get students up off their chairs and moving around and talking to each other and challenging themselves through these different techniques and theories to really understand clinical practice. Here at Case Western, I've listed out a variety of courses. I'm not going to go through every single one of them, but I feel prepared to teach pretty much all of the direct practice courses and theory-based courses. Direct practice, generalist methods and skills, problem identification, screening and assessment and diagnosis, social work with groups, research methods, etc. And obviously, given my sort of background in mental health, path of study specialization around mental health would be, I would feel pretty adept at. Also feel pretty confident teaching in the PhD program around advanced research methods and sort of research theory, social work theory. And so you probably asking yourself, why am I standing up here? Why do I want to be here? Well, there's several reasons. Well, Case Western is obviously a leader in social work education. It's been obviously nationally ranked for some time, and it's a historic university in the social work profession. The programming here is very much combining research, practice, and theory to hopefully develop a really strong generation of social workers. I really appreciate the different paths of study where students can choose a path that they're most interested in and become experts, if you will, in that path and how to engage with that community, which hopefully will help multiple communities down the road. And then, of course, the doctoral program is robust and rigorous and is educating the next generation of social work educators and researchers. And the faculty here are renowned in their focused areas, and they are doing innovative research to create really big change. Everyone's topic is somewhat wide-ranging, but applies to practice and policy in really unique ways. And then, of course, the training institutes and research centers. I think there's a really great emphasis on that here, which I would like to collaborate with and be a part of. So being a part of that kind of community is certainly something I'm interested in. And just to wrap things up, I just want to briefly mention and thank my network of mentors and collaborators that have really brought me to this place and helped me get to be in front of you all. So this is I like to say this is my global and international, because I have one person in Australia that I work with. So just get someone in Australia or something. No, I'm just joking. So yeah, this is a great community of scholars that have really helped me. So I just want to highlight them. And I will thank you all for being here. And I'm going to put up the little link. So there's your link. You can go and rate this. I won't tell anybody. No, I'm just joking. So thank you all for being here, and I'm happy to answer any questions.
So you need to use the microphone if you want to ask questions, because it's being recorded. So questions or comments?
Hi, Mark Singer. I'd be curious about your opinion of the role of some of the main male sports in eating disorders, like football, wrestling, gymnastics, dancing.
Yes. Excuse me. What I would say is a lot of those like weight-focused, weight-bearing sports do have an emphasis and have an association, especially among men, because over-exercising is very common among the male population as an eating disorder behavior. Not surprisingly, like I mentioned, the performance-enhancing substance use, the legal and illegal, is often connected with sports performance. So yeah, there's a huge crossover between athletics, especially among males, and eating disorder or those performance-enhancing substances. And I was talking earlier, and we were talking about you can't watch a football game without hearing the objectification of a male body. Like, this guy is X size, X height, X weight, X percent body fat, can jump this high, can run this fast. And so I think implicitly we are feeding messages to our young boys that you have to be a certain way. And I think that contributes to all of this. Yeah.
Hi.
Hi.
In layman's terms, can you roughly define what would constitute a positive screening for an eating disorder? Like, how many times would I miss dinner a week before I would be diagnosed with anorexia?
Yes, I'm going to go off of this slide for 1 second. I'm prepared for your question. So these are the measures of the SCOFF tool right here. These are the 5 questions. Do you ever make yourself sick because you feel uncomfortably full? Do you worry about that you have lost control over how much you eat? Have you recently lost more than 15 pounds in a 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say food dominates your life? So if you say yes to 2 or more of these questions, you screen positive for an eating disorder. The problem with this diagnostic measure, or I should say the screening tool, is that these are not 100% tailored towards the male experience, which is not going to really ask about thin. Like, thin is not really a term that males with eating disorders really use. They use muscular, they use lean, that's what they're seeking. Lost 15 pounds in a 3-month period, it's really unlikely for a man to lose that amount of weight. Women often do lose more weight in their experience, especially with anorexia. But even men with anorexia, they're not actually losing that type of weight. They maybe lose a little bit of weight, but they're often in the higher categories. So the SCOFF tool, this is what would sort of categorize it. I think if we could change this tool to be more specific to men, we would ask more questions about weight gain and muscle enhancing behaviors and muscularity and leanness, things like that. Does that answer your question? Yeah. Okay. Yeah.
Okay, I'm glad you're on this slide because you have scoffed this tool.
Yes.
And yet your studies are all based on it.
Yeah.
Right?
Yep.
So I would suggest that in your research agenda, it's to develop a valid tool.
Yes, there was a nice new tool that just came out actually. 2 of my collaborators and several others just developed. It's called the Muscularity Oriented something tool, MOET, MOET. I can't remember what the E is for. But yeah, it's much more, it's a short questionnaire. I think it's maybe 10 questions, 5 to 10 questions, and it really targets those similar questions. And this is the limitation of secondary data analysis, is this is what I'm given. But yeah, I totally agree that using that tool to really capture a large sample like this would be really powerful to be able to do. Yeah, it's a good observation. There's a hand over there somewhere.
I'm not sure. Can you hear me?
Yes.
Yeah. Okay. Sonia Minas. I have a question about your research question number 3 or aim number 3.
Sure.
I think it's a really interesting question about sexual victimization and emotional regulation
yes.
and how that might tie into eating disorders. I'm wondering if you can comment, and I understand this is cross-sectional data,
Yeah.
but I'm thinking about the mediator as being, but it's cross-sectional, right? And so you're looking at a mediator. If you can comment about the issue of sexual victimization in the last year and how that might have affected that model or the outcome.
Yeah, it's a great question. I would say that, so only one of the SCOFF questionnaires has a time frame. It's that have you lost 15 pounds in the last 3 months? So we don't know really when someone is, those questions are not time-based in any way, whereas like you're mentioning, the sexual assault question has a period, right, 12-month period, as do the other variables. So I think generally we just don't know what's happening first or second, essentially, if that's kind of what you're asking. And I think that's just a major limitation of this data, is that it's cross-sectional, and I can't say when is X happening. Do you want to clear up? Okay. No, that's okay. I like it.
Quick follow-up,
Yeah.
just a thought.
Yeah.
The exact age, so sexual victimization in the last year means there are lots of other years
Right, yes.
that could have occurred that
Yep.
isn't really captured in this, and that there
Yep.
might be some developmental aspects
yep.
of when that occurred
Yep.
that might be important in terms of
Absolutely.
the outcome.
Yep. And also the connection.
Just a thought.
Yeah, and also the connection of childhood sexual abuse. Childhood sexual abuse often leads to sexual assault, which could potentially, so you're talking about multiple sexual victimizations and traumas that have happened along the way that might have led to this experience, right? So yeah, I agree with you. Yeah.
Good question.
Okay, you answered it while you were talking.
Cool.
So we're good.
Good. Let me put that thing up so in case anybody needs the survey thingy. Sorry, there you go.
Other questions?
We have a lot of students here, so we're going to be very interested in your responses to
Yeah,
the survey.
absolutely.
Really, go to it now. We're all on the smartphones out.
Yeah. Yes, go do it.
On muscle enhancing behavior, what would eventually constitute something that's problematic with muscle enhancing behavior? I guess I'm kind of confused overall what you're looking into that, because I've always seen like, oh, you go to the gym and you like build muscle and you like look good and feel good about yourself. Has always been like a good thing. So when does it turn into a problem?
Yeah, that's a good question. I think it's around functioning. Like when is the behavior taking over either functioning around like school, not being able to go to school or not being able to focus in school. It could be around work and employment, having issues with work and employment, having relationship issues. And then there's also the outcomes, right? Is there problematic health, psychological, social outcomes from the use and doing of these behaviors? So are you getting injured? Are you having cardiovascular issues? Are you engaging in these substances that are leading to more problematic substance use? So it's a multifaceted thing of assessing the problem. And I think we also don't really know 100% like how to actually I think this is part of the problem. You're highlighting a problem, which is we don't actually know 100% how to say when is it a problem or when it is not. Does that make sense? Yeah. Yeah. You and I are going to have a good conversation afterwards.
So like, how would you even look for, like, screen for something like that? Like, I feel like that would be a very invisible and hard to detect problem versus like traditionally like something like anorexia in women, where it's like clearly you could see if somebody's like malnourished, but if somebody's just like kind of fit but not like super jacked bodybuilder, but yet it still could be problematic, it'd be hard to detect. So how would you screen for something like that?
Well, first of all, that muscularity-oriented tool I was mentioning does ask questions around distress, like anxiety, depression, things like that, obsessive-compulsive thinking. So you can ask the questions that are connected to like those traditional like levels of distress, like anxiety, or it's hard for me to function if I don't do this thing that I was supposed to do, right? And I think you're hitting at another really important point, which is it's invisible, right? We see people go to the gym, guys who go to the gym and they work out, and we're like, hey, good, go for you, man, good job. But he might actually be in a significant amount of distress. He might have lost relationships. He may be struggling to hold a job. He may be abusing substances. And so it becomes very normalized to just overlook that person as having some sort of issue. Does that make sense? Is that helpful? Yeah. Yeah. I mean, you're hitting at really important points that I think we're still trying to figure out.
I can't remember if you mentioned this or not, but does your future research at all plan to focus on not college enrolled males? Because I feel like those numbers might vary differently between if they're enrolled in college or not.
Yeah, definitely. Yeah, absolutely. So I've done a lot of secondary data analysis, and these 3 studies were using a college health data set, but the Ad Health data set is a longitudinal cohort study, so it's following people over many years, and that includes non-college enrolled people. So certainly that is a data set that I'll be using for the future, but also collecting primary data and being outside of the college world. That being said, adolescence and young adulthood, which often includes college, is a primary time for eating disorder development and the problematic use of these behaviors. So it will probably be a part of the future research agenda. It's a good question, though. Hi.
I'm Aloan Townsend. I noticed that much of your research so far is individualistically focused. So to what extent is the social environment important in what you're studying?
It's a very good question. Yeah, I think that's a really good question. I think most of the research, you're right, has been very much focused on sort of individual and individual factors. I think some of the research that I hope to do in the future is sort of understanding a little more nuances, like some qualitative data that really understands why men might use these performance-enhancing substances, which I hopefully would gather some more of that, like larger kind of environmental, social factors that are contributing. And then I think I do hope to sort of collaborate and get involved in like primary care settings and use those as collaborators to understand kind of environmentally and socially what's happening for people individually. So right now it's been a little more focused on the individual factors, I think partially due to secondary data analysis, but hopefully in the future it will expand out and be a little more environmentally focused as well. It's a good point.
Okay, well, thank you all for
Thank
attending.
you. Thanks.
Thank you, Kyle,
Yeah,
for your
thanks.
presentation.
Absolutely. Thank you. Thanks.